Okay, the next case that we're going to do is chief complaint, why is my baby yellow? Let's look at our history. You have a 30-year-old woman, estimated gestational age 40 weeks, who comes to the labor and delivery room with contractions of 3 minutes and spontaneous rupture of membranes for 2 hours. She has gestational diabetes, which is diet-controlled. Her blood type is A positive. Pelvic examination reveals 4 centimeters of dilatation and 90% effacement, and the vertex at -2 station. Labor is augmented with oxytocin and progresses without complications. The patient has a girl with APGAR score 9 at 1 minute and 9 at 5 minutes. The patient also had forceps assisted over a right mediolateral episiotomy. Her birth weight is 3,800 grams. The newborn examination by the pediatrician seems to be appropriate for gestational age. The infant is breastfed without difficulty upon discharge from the hospital. 2 days after discharge, the mother brings the newborn to the office because she notes her baby appears to be yellow. Physical examination is within normal limits, except for the clinical jaundice, especially in the face. Now, the thing that we need to note here in the history is that this baby appears to be normal, but 2 days after birth, the patient presents yellow. The patient has jaundice. And so it's going to be your responsibility as the physician to determine why, or what else, or what other steps, if any, need to be done. So let's think about our differential diagnosis for an infant who has jaundice or who is yellow on the 2nd day of life. Well, first of all, the most frequently seen would be physiologic jaundice. The second would be that the patient has some type of acute hemolysis. All right, remember that our patients are leaving earlier these days after 24 hours, and this may not have been caught by the doctor or the nurse taking care of the patient. Other things that could cause jaundice would be hemoglobinopathies. Infection or sepsis could cause the patient to be jaundiced. We could have some type of anatomical problem, such as obstruction of the biliary system, and the patient could have kernicterus. So all these things you need to be thinking about, you need to be ruling out. So what would be your next step to help you? The first thing that you would want to do is to obtain a good history from the mother and a good birth history, which is really essentially what you have here in our case. The next thing that you would want to make sure that you chose was to do a bilirubin level. You want to see what the total bili is, what the conjugated bili total is, and what the unconjugated total is. It would be important to include a complete blood count. This would help you looking for anemia. It also would help you to look for signs of infection. It also would help, if we looked at the peripheral smear, to see if the patient had any type of hemolysis, any spherocytes on the peripheral smear. Other things that you would want to do would be the Coombs test. You look at your results, and you see that your bilirubin level is 9 milligrams, which is predominantly unconjugated. You look at your CBC, and you feel that you have a normal hemoglobin. If you have a normal hemoglobin, you probably don't have hemolysis or an acute process. You look at your Coombs, and it's negative. Now you need to be thinking, so out of that differential diagnosis, how can I rule the diagnosis in or rule it out? Well, first of all, you should know that jaundice occurs in 50% of all newborns and reflects an accumulation of unconjugated bilirubin in the blood and other tissues. It can be clinically observed at blood concentrations of 5 milligrams per deciliter or greater. And that there are 2 types of jaundice that are recognized, physiologic and non-physiologic. All right? I'd like to add that we can also see breastfeeding jaundice or breast milk jaundice. So as a physician, your responsibility at this stage is to say, is this physiologic jaundice? Is there a pathologic process going on? Or does my baby have breast milk or breastfeeding jaundice? So that's the bottom line. That's what you need to be considering here. So how are you going to do that? What would be your treatment plan? What would be your next step? Well, first of all, this patient is a normal birth. The patient has really no risk factors. The CBC is completely normal. The Coombs test is completely normal. The baby is 2 days old, and you know that at 48 hours that you're going to get a peak of bilirubin that's most likely associated with physiologic jaundice. In physiologic jaundice, the treatment would just be to reassure and monitor the bilirubin levels. So you might get another bilirubin level in a day or so to see if it goes up or down. Remember that in physiologic jaundice, that the bilirubin level should never really be above 12. If you have a bilirubin level of 15 or 16 or 17, it's not physiologic. However, this level of unconjugated bilirubin, 9, is well within the means to make the diagnosis clinically with the history that you have that this is physiologic jaundice. Therefore, really, no further treatment would be necessary. You would tell the mom to continue feeds, give fluids, putting the baby near a window with sunlight may help, but there's really nothing to do. Now, I told you that it would be your responsibility to, at this time, differentiate physiologic versus the pathologic or non-physiologic versus breast milk versus breastfeeding. And so how would you do that? Or what would be key, or what would you be looking for? And why is it important? Who cares? Why should we care? Why do we make such a big deal about bilirubin in these infants? Well, the main reason that we make a big deal about it is that these young infants who have hyperbilirubinemia, if it goes too high, it can deposit into the brain. So what? The patient will become neurologically devastated, or the patient can die. So that's what we're trying to avoid. We're trying to avoid something that's called kernicterus. All right, so how would we approach a newborn who comes in yellow on the second day that had a level that was 15 or 16? It can't be physiologic jaundice because I said that the bilirubin level shouldn't be higher than 12. Therefore, your responsibility as physicians is to work that patient up. You need to have a good history of the mother. You need the mother's blood type. All right, you need the baby's blood type. You need to make sure that you have a Coombs test. All right? You need to make sure that you look at your peripheral smear, checking for hemolysis. Check your CBC to look to see if you have anemia. You might want to do a retic count because if you're having a hemolytic anemia, reticulocytes will be elevated. What else do you need to be thinking about in these small babies? Did the mother have any history of syphilis or sexually transmitted disease? All right? What kind of delivery was it? Was it a premature baby? All these things you want to be, thinking about. Could this baby be septic? Because sepsis could contribute to this hyperbilirubinemia. You must remember that if the patient has a bilirubin higher than 5 on the first day of life, it's always pathologic. You cannot attribute that to physiologic jaundice. So a bilirubin level of higher than 5, a total bili higher than 5 on the first day of life has to be attributed to some pathologic process going on, and your job is to investigate it. All right? Now, you might say, well, Dr. Kerner, they tell me that this lady is breastfeeding. How do I know that this baby doesn't have breastfeeding or breast milk jaundice? And what's the difference between the two of them? Okay? Breastfeeding jaundice can occur within the first week of life, or it can contribute to the jaundice. All right? It's usually because the mother's milk hasn't come in fully yet, and the baby is a little on the dehydrated side. However, if they put this on the second day of life, the key point that they're trying to hone in this baby with a bilirubin of 9, is that it's physiologic. Because this breastfeeding jaundice is just going to contribute just a small amount. It's not going to put you over the edge into the 15 or the 18 level of bilirubin. What about breast milk jaundice? Patients that are breastfed sometimes have elevated bilirubins. Usually not seen until after 7 days of life. Therefore, if you have a 2-day-old, a 1-day-old, who they're trying to get at as far as bilirubin, breast milk jaundice is your diagnosis of exclusion, but breast milk jaundice has to occur after 7 days. So you're not going to diagnose breast milk jaundice, you're going to cross that one out. Okay? Now you're going to say, well, how good could breast milk be if it's giving us jaundice? All right? But the idea here is that it causes jaundice, but even though the bilirubins are elevated, there's never been an associated case with kernicterus. And that's what you're worried about, the kernicterus. And so what you need to be thinking about is breast milk is giving you very good components for nutrition for the infant. It's the best way. Therefore, we use the breast milk even though it can cause jaundice in some individuals, because the jaundice will not have a deleterious effect. All right. And so what if the patient comes in and it is the 8th day or the 7th day and the mother has a history of feeding? Can that be breastfeeding? Can that be physiologic jaundice on the 7th day? No. Physiologic jaundice has to be in the first 48 hours. Okay, 36 to 48 hours. No way. So you can get rid of that one. If it's a later jaundice, that's history, that physiologic jaundice. All right? What if they say to you, though, that this breastfeeding jaundice, or they're not going to tell you it's breastfeeding jaundice, what if they say that this jaundice, this patient, has a bilirubin level of 22? Well, let me tell you, if you didn't know, a 22 is pretty darn high. All right? If we're saying normal is less than 12, 22 is almost double. The question then is, should you get excited? Well, first of all, we said that breastfeeding jaundice is a diagnosis of exclusion. Therefore, what you need to do is to rule everything else out. Rule out the pathological first by doing the test that we previously discussed. Now, if everything seems to be perfect, you have your diagnosis. The baby is breastfeeding and it's breastfeeding jaundice. But the question will be, what is the next step? What should you do? Should you tell the mother the milk is no good? Stop the breastfeeding? Should you continue? It's 22. Maybe by the end of the week it'd go as high as 30. So you're in a dilemma. There are 2 correct answers. They can only give you one on the examination, but you must know both correct. The first one is that you can do what a lot of my friends do. Continue the breastfeeding. Even if the bilirubin goes to 25 or 26, no big deal, because there's never been evidence in the literature that kernicterus has occurred with breast milk feeding. However, the other alternative, which is also accepted by the American Academy of Pediatrics, is that you could stop the breastfeeding for 48 hours and just have the mother pump her breast, repeat a bilirubin level, and the bilirubin level should be lower. So if you had a 22 Billy, you might now only have an 18. And then restart the breast milk feeding. When you restart the breast milk feeding, you're going to have a rebound effect. The jaundice or the hyperbilly is going to go a little higher, but it will never go as high as the original number. So if you had a 22 and now you're an 18 and you restart the milk, you might go as high as 20, but you won't go back to 22 or higher. Either is correct, but make sure the key is that you've ruled out the pathologic process. All right? Now, we've talked a little bit about kernicterus, and we've said that you want to avoid that. Well, if kernicterus is not occurring with the breastfeeding jaundice, when does it occur? Doesn't occur with physiologic jaundice. Therefore, it has to be the pathologic process. And so what we want to make sure that we think about is, how high is too high? There are grids that doctors use to look up in hours from birth to the hour of life and the value of the bilirubin to see if they need to start any type of therapy. The therapy to help break this billy down is what we call bilirubin lights, okay? Where you have the baby in an incubator and you have a bank of lights shining onto the baby, all right? If the baby is having a rapid rise of bilirubin, i.e., a bilirubin higher than 5 on the first day of life, you're going to work that baby up for complete sepsis, spinal tap, the whole deal. Okay, because you don't know that the baby's not septic. Okay, you don't know that this baby has some kind of spherocytosis. You have to first think also sepsis, but you would probably start that particular baby under billy lights. If the baby continued to get worse, you might use 2 sets or 2 banks of lights. Now, if you have all this light coming on the baby, what else do you have to worry about as doctors in the treatment? Hydration. I heard somebody say that. That's great. You have to start fluids on this baby and account that this patient is having, sensory losses. The other thing that you need to be thinking about is if it continues to worsen, then you may end up having at some point to do an exchange transfusion. So that's really the way that you should approach every case of the neonatal jaundice on your exam. Thinking about the day of life, thinking about what is the bad, what would be the outcome, and what really is my goal of therapy. Now, in this particular case, the final diagnosis was physiologic neonatal jaundice. Again, just to highlight, it's not present in the first 24 hours of life. You'll never have physiologic jaundice on the first day. All right? That the bilirubin concentration peak is usually around 12.9 by the 3rd to 4th day of life, so usually less than 12 is what they're going to give you. And it resolves usually by 7 to 10 days, and it's predominantly unconjugated bilirubin. If we look at hemolysis, key words that could help you to diagnose this is that you would have an ABO or RH incompatibility. G6PD might be an example of hemolytic process or spherocytosis. I can tell you that on your exam, sometimes they actually tell you that spherocytes are on the slide. So you have a baby with jaundice, and if you just read what the peripheral smear was, it would say spherocytes present. If spherocytes are present, then most likely the patient has spherocytosis. They are not trying to trick you. All right? So don't read more into it than's there. These patients with hemolysis usually have a positive Coombs, and again, their bilirubin problem is unconjugated. If we think about hemoglobinopathies, we're talking about things like sickle cell disease or thalassemia. This is usually not a problem right on the first day of life or second day of life. Remember that especially the children with sickle cell disease usually have fetal hemoglobin, even well up to 6 to 9 months of age. Therefore, if we're talking about jaundice in the newborn period, and they have answers such as thalassemia or sickle cell there, it's probably not the correct answer. Other things that you could have as far as problems with jaundice. Biliary atresia. The buzzwords for this would be that you'd have clay-colored stools or colic stools, whitish. The problem with biliary atresia, as opposed to the other points that we've been discussing, is that usually the biliary atresia has a problem with conjugated hemoglobin. And then lastly, what we talked about as far as the kernicterus, these patients will have neurological problems. And usually, probably within the first week of life, they may come in what we call opisthotonus. All right, what does opisthotonus mean? It means that the patient is arched. Okay, so if this is our table, there is a gap between, this is the patient's head, this is the patient's leg, and there is a gap there. Okay, opisthotonus. The patient may also have seizures. And by this point, with this bilirubin that's depositing in the brain, they're either going to have mental retardation, poor neurologic outcome, but as I said, without intervention, and even with intervention, it may proceed to death. The next case that we're going to look at is the chief complaint of mild pain in the inner right groin and thigh. If we look at our history, we have an 8-year-old boy who's brought to the office because of a 3-month history of a painless limp of his right leg. He states that he limps intermittently after activity, but for the last 2 days it has been constant. He also complains of mild pain on the right groin and in the inner thigh. He is afebrile, he has normal vital signs, and he appears to be well. If we looked at his physical examination, we would see that his HENT exam is within normal limits. His neck is supple. He has no lymphadenopathy. Cardiovascular exam is a normal rhythm with no murmurs. His lungs are clear to auscultation. His abdomen is benign. His extremities, however, show a decreased range of motion of the right hip in abduction and internal rotation, and a positive Trendelenburg test, which indicates gluteal weakness of the affected side. Neurologically, he's nonfocal. His cranial nerves appear to be intact. He has good muscle tone, no clonus, and the reflexes are +2 and symmetric. Now, some of you might say to me, well, what is this Trendelenburg test? This has to do with the type of gait that the patient has. And if the patient has a Trendelenburg positive test, what is happening is that the patient is lifting up their foot and kind of shifting their weight to the one side, all right? So you see them walking like this, all right? So this is how this young boy walks. This is not normal for a 9-year-old or 8-year-old. So let's think about our differential diagnosis. What are some of the things that might cause us to have, or might cause this young male to have pain in the groin, and gluteal weakness? Well, if we have a hip problem, we could be thinking about septic arthritis. You never want to miss a septic arthritis. Key here is that you don't have to have fever, all right, and you may present with a limp or with pain. Oftentimes, when you have hip pain, it refers to the knee. So whenever you're thinking about doing x-rays, always get both a hip and knee films. What other things do we need to be thinking about? Transient synovitis. The synovial fluid has some infection. How do we get that? Usually there's a history of an upper respiratory infection. The next thing on our differential diagnosis, slip capital femoral epiphysis. Slip capital femoral epiphysis is just that, a posterior medial slip of the femoral epiphysis. However, those children are usually obese. We don't have any history of that in our case discussion here. Other things that can cause us to have a pain in our inner thigh or hip would be juvenile rheumatoid arthritis. All right, so consider that. The patient may have had a stress fracture. The patient could have a tumor. Okay, the patient may have an osteosarcoma that's been undetected. The patient may have a conversion reaction. Okay, the patient just for some reason may be walking or limping or maybe trying to imitate somebody. Right? And the other thing that this patient could have would be Legg-Calvé-Perthes disease. Now, let's think about how we would start to diagnose this. Well, first of all, since you need to rule out infection, you don't want to miss a septic hip, all right, and you want to get the most bang for the effort that you're putting in, if you could only do limited amounts of exams, what you would need would be a CBC with differential, looking for evidence of elevated white cells for infection, all right? Other things that you would get were the erythrocyte sedimentation rate, seeing if that was elevated. And then you would also get films of the hip, pelvis, and the key here would be that they would be in a frog leg lateral position and an anterior-posterior position. And they will ask you on the exam, what views do you need? And you need to know that a frog leg is an important view to get. All right? And if you're thinking frog leg, what is frog leg? Okay? If you think about back to your biology days when we dissected the frog, you remember that the frog's legs extend in a V like this. And that's the way the hips would be on the radiographic film. All right? So now let's look at our results. Well, first of all, they did the X-ray, and what they find is that there's a complete collapse of the femoral head. Now, you know that the femoral head is like a ball. It's rounded, it's curved. When they say that there's a complete collapse, what they mean is that if you thought of that femoral head as an ice cream cone, scoop, that it's melted. It looks like a melted ice cream cone. Okay, it's starting to flatten. The other things that you need to know here as far as our results are that the CBC was normal. And in all these cases, CBC may be plus minus helpful. The SED rate was also normal. Why is the SED rate important to get? It's important to get because if for some reason this patient who presents with thigh pain has an osteomyelitis, the SED rate is the best way to follow an osteo. Okay? Now, thinking about our assessment, if this patient had a septic arthritis, most likely the symptomatology would be more acute. And the patient may be showing more signs of systemic illness. Could have fever, but not necessary. All right? The other things that we want to be thinking about are transient synovitis. We said that the patient would be a post-upper respiratory infection, and so really wouldn't look ill. And the upper respiratory infection would have probably occurred 7 to 14 days previously. Remember that in slip capital femoral epiphysis, that there's a history of, could be a history of a minor injury, but doesn't have to have any injury. There's a history of suddenly the patient doesn't want to limp. The patient doesn't want to walk, excuse me. And so the patient may be just holding their leg out to the side. And when you go to AD duct, the patient refuses, or the patient is giving you resistance. Now, what else do you need to be thinking about? How about juvenile rheumatoid arthritis? We talk about that with hip pain, thigh pain, knee pain, bones, joints. What about that? Well, usually there's an increase in SED rate. Sometimes you can have eye findings, depending on the subtype of juvenile rheumatoid arthritis that you have, like iridocyclitis. Or if you have a systemic juvenile rheumatoid arthritis, you might see days where the patient has fevers that come and go. You might see rashes. You might see some other systemic problems. So you need to think about your physical exam. It's important to hone in on your physical exam and your radiograph to really help you. Once you've seen that the patient has that flattened femoral head, you pretty much have your diagnosis that this is really going to be Legg-Calvé-Perth's disease. And remember that if you're going to say, especially in an emergency center or an office, that somebody has a conversion reaction, that should be your last diagnosis after you excluded all other forms of organic diagnosis that you could make. So what would you be responsible for as a physician? What's your treatment plan? What is this Legg-Calvé-Perth? What's happening? Why is the femoral head seeming to flatten or be destroyed? And nobody really knows. Okay? The etiology is really unknown. However, some of the things that we need to be thinking about are that what are the stages that this goes through? Because over time, what happens is that the femoral head is round. It's an avascular necrosis. It's thought to be caused by that, although not understanding exactly what the mechanism is. And the blood supply is not getting properly to this femoral head. So we're going to go through a problem that it's not going to grow properly. Then what's going to happen is that it's going to start to fracture. Then what happens is that it's going to start to reabsorb. Then we're going to have reossification and then healing. But what's your problem? What's your goal of therapy? Your goal of therapy is that you hope that it will heal properly and that it doesn't heal with some flat portion. Okay, that it goes back to an exact curvature. If the patient has this Legg-Calvé-Perth, then one of the things that you could advise is physical therapy. Other things that you might want to do or consider is containment of the femoral head. You want to make sure that you prevent further collapse. And if the patient is actually less than 6 years of age, probably it would be conducive just to observe. All right? Now, what other things do we need to be thinking about as far as our case review? We said septic arthritis. Buzzwords or keywords that you would have would be that the patient is febrile, that the patient would have exquisite pain, they might have joint swelling, and if they asked you on your test what the next step is, it would be an arthrocentesis. All right? You must get fluid, to evaluate if you suspect that the patient is having a septic arthritis. You're going to send it to the laboratory and look to see if there's increased white blood cells. Transient synovitis, we said, is usually preceded by a URI or varicella or a pharyngitis. And you may also think that this joint has fluid. However, if you did your arthrocentesis for the transient synovitis, there wouldn't be an elevation of the white blood cells, so you would know that the patient did not have a septic joint. What about the slipped capital femoral epiphysis? We said that the patient is usually obese. We said that there is a characteristic X-ray, and that would be the frog leg, and you would see that the patient had a posterior medial slip of the femoral epiphysis, okay? The other thing that you would want to know as far as a pearl and as far as a generalist or a pediatrician specializing and something that's a pearl for your exam is that this can be associated with endocrine problems. So if they say to you that this patient has slipped capital femoral epiphysis, the next step would be, after you've done your diagnosis with the x-rays, would be to draw a thyroid study. And the reason you do this is that these obese children who have slipped capital femoral epiphysis have an association with thyroid disease. So that would be your next thing that you would do. As far as juvenile rheumatoid arthritis, it's a longer course. Again, you might see joint effusion. Sed rate, though, is usually elevated. And there may be other findings depending on the subgroup that this juvenile rheumatoid arthritis is in. What if the patient had a fracture, such as a stress fracture? You might have had in the history that there was a prior injury. If you palpated along the femur or along the thigh, you might find point tenderness, which we did not find in this child. In fact, this child had a painless limp. You might find some swelling or evidence that there was trauma. And again, you would see the fracture on X-ray. This will bring us to our next case, which is the unknown immunization status. If we look at the history, we have a 5-year-old boy who immigrated to the United States from Ecuador 6 months ago and is brought by the office by his mom before he starts school. The mother has lost his immunization card, and she is unsure which immunizations he was previously given in Ecuador. So stop right there. This is a patient who's 5 years old. You would assume as a physician that this patient had previous immunizations, whether he's in Russia, Ecuador, or Canada. The mother, though, has lost his card. Once the mother has lost his card, it's like he didn't have immunizations at all. Even if the mother could remember that the patient had the DPT or tetanus, or if they thought the patient had a Hib, it doesn't count unless it's documented. Okay, so right now you know that you as the physician, prior to this patient going to school, is going to have to probably restart his immunizations. So you're going to do a physical examination. And you have a cooperative 5-year-old who really has a normal physical exam. And there's no evidence of rashes, no neurologic problems, and he appears to be a normal child. And so you need to really assess the situation, because your job is to determine what immunizations is he going to need. So we have unknown immunizations, and really we need to be thinking about, for the first visit, what should I be giving this child? Well, the first thing that we need to be thinking about is what do regular children or children who are following the immunizations on a regular basis get? And what does this patient need in order to get to school? The second thing that we need to be thinking about is, I'm giving the immunization so that I can prevent disease. Is this disease significant in the age group that this child is in? All right? So those two things should help you in your assessment. Now, what types of vaccines do we have, or what do we know about? Well, first of all, we know about diphtheria, pertussis, and tetanus, the old DPT. It's rarely given, but it's something that you should still know about. The Japanese made a more purified or a better form, a new improved form of the diphtheria, pertussis, and tetanus vaccine. You might know from the literature and from your practice that we had some problems with pertussis in the past. By adding a new component called acellular pertussis, we've had less side effects. The side effects of the old DPT were, again, neurological problems, seizures, increased fever. So we've seen less of that with the diphtheria, tetanus, and acellular pertussis. So on your examination, it's recommended that you would choose DTAP for any time that the child needed a diphtheria, tetanus, and pertussis. Other things, other types of vaccines that we have to consider to give to this patient are the hepatitis B vaccine. Right? Does this patient need that? He's coming from a third world country. Maybe he already had hepatitis. How about the Hib, the Haemophilus influenza B? We know that Haemophilus influenza B was a big problem in the 1970s and 80s, especially for causing epiglottitis in children, especially causing meningitis in children. And it predominantly affected small infants, less than 2 years of age. We also need to be thinking about the fact that although we still consider Haemophilus influenza B in our diagnoses when we're thinking about meningitis, that usually children that are greater than 5 years will not have this disease. What other things do we need to be considering here as far as vaccines? The measles, mumps, and rubella vaccine. We know that in the early 90s that there were big outbreaks at various universities across the states of people who had been vaccinated in the 50s and the 60s and even in the 70s who got a form of measles. Therefore, we want to make sure that our patient has a measles, mumps, and rubella vaccine. They talk here about inactivated polio vaccine. You know that there are two types of polio vaccines, the oral polio and the inactivated. Because we're such a diverse land and we have so many people who are immunocompromised, both with HIV and also who are on steroids chronically for renal disease or who are immunocompromised because they are on radiation therapy or some kind of chemotherapy, that we've changed from the oral vaccine in this country to the inactivated polio vaccine. Why? Because every time we gave the oral polio vaccine to somebody, there was a type of herd immunity where, since it went through the gut, if you changed the baby's or the infant's diaper, that you were actually, getting some of that vaccination component. And if you had patients in your household who were immunocompromised or on dialysis or had problems with leukemia, it would cause a problem for the family because that patient would be placing the immunocompromised person at risk. Therefore, if you have a test question, inactivated polio vaccine is the way to go. Now, as far as the final diagnosis, we need to give general immunization. So what would I give on the first visit? Well, first of all, I need to give diphtheria, pertussis, and tetanus. And when we say DPT, we would say diphtheria, acellular pertussis, and tetanus. The other things that I would need to give would be a hepatitis B vaccine. It doesn't matter that the person is coming from Ecuador or Russia or any other place. This would be something that we would give this child. We need to make sure that the patient has the measles, mumps, and rubella. And we want to give the inactivated polio vaccine. The note here is that if this patient had been older than 5 years of age, remember that we said that most likely people who are older than 5, unless they have some kind of immunocompromise or are alcoholics, or maybe in the geriatric population, they wouldn't have an infection with Haemophilus influenza B. Therefore, if the patient had been 10 years old, we would not have given that vaccine. All right? Because you always want to weigh in your mind, is the benefit of the vaccine better than the risk of obtaining it? And what would the value be to that patient? Now, this patient has to get to school. This patient, will need to get more vaccines in order to participate in the classroom. And so what else do they need? Or when is the first time that I can catch them up? And so you're going to bring them back in about a month. And at that time, what you're going to do is you're going to give another diphtheria, acellular pertussis, and tetanus. You're going to give another hepatitis B vaccine. And in 2 months, you're going to come back to get your third DPT. Why? Because you need to have a series of diphtheria, acellular pertussis, and tetanus in order to be immune. Remember that in the small infant, we give those at 2 months, 4 months, and 6 months. All right. Now, what else do we need to know? Well, first of all, we need to know that the patient is going to need, all patients are going to need boosters of these vaccines. And in your note packet, what you should see is a recommended childhood immunization schedule. And I think that a lot of students who come to the course, especially if they're not involved in pediatrics, will always say to me, I'm just going to skip those questions. I'm not even going to learn the immunizations. And I would ask you to not do that. One reason is that this test is asking you to know what a generalist should know about immunizations. So they're not asking you every major exception to the rule, but they do think that in order to call yourself a doctor, that you should have some general knowledge on how to administer immunizations. The other thing that I want to remind you is that these test questions are weighted equally. And if you stop and learn something well, it's a point that you're going to get. If you keep saying, well, I won't learn that, that's too hard, I'll let this one go, before you know it, you have a great percentage that you've already missed points on. And the idea is to capture every point you can. Now, what I'd like to say is that if you look at your immunization schedule, underneath the schedule, you'll have exceptions to the rules. And it's the exceptions to the rules that you would probably need to know in order to pass the examination. And so what I'd like to do is just to run through each vaccine and to just discuss, how it's administered, and in the rare case or the exceptional case, what as a generalist would you need to know if somebody asked you. And so if we look at the hepatitis B vaccine, we know that it's initially given at birth and that we give the second dose usually 1 month later. We then would give the third dose pretty much at 6 months of age. However, what you need to know is that if the mother is hepatitis B surface antigen positive, then this is a red flag for you, especially on your examination or in your practice. And the reason being is that this mother most likely has a chronic hepatitis. This baby has been exposed to that in utero. Now, some of my students in the other class said to me, well, Dr. Kerner, then that means the baby is immune. That is absolutely wrong. If the mother has chronic hepatitis, the baby has been exposed to that in utero. That means that this baby is at risk for developing hepatitis himself or herself. Therefore, just to get a hepatitis vaccine is not sufficient. You must give something else to help, because remember, with active immunization, it takes a while in order to make antibodies. The baby may be getting sicker and sicker before that time. Therefore, what you need to do is to make sure that you, in addition, give the hepatitis B immunoglobulin, which is called HBIG, HBIG. All right? So for these particular patients who have a mother who's hepatitis surface antigen or hepatitis B surface antigen positive, you need to give the HBIG. Now, is there a time limit? Yes, there is a time limit. You need to administer that to the mother, or to the baby, within the first 12 hours. What if it's 14 hours? What if you were on the floor doing a procedure and you forgot to go back and give the HBIG to the baby? Give it. But it's most beneficial in the first 12 hours. What if you didn't know what the mother's surface antigen was? That could be another question. You're obligated to give the baby the hepatitis B vaccine. You're also obligated to draw a hepatitis B surface antigen on the mother. If it comes back positive, you are obligated to give the patient hepatitis B immunoglobulin. And it should be administered within the first week of life. All right. Now, let's look at some of the others. All right. We said that for the diphtheria, tetanus, and pertussis, that we really need to be using the diphtheria, tetanus, and acellular pertussis. We also want to talk about the Haemophilus influenza type B. The Haemophilus influenza type B vaccine can sometimes be a little confusing. And the reason is that there are three types of vaccine out there. So there's different people making different vaccines. And it would be like, let's consider toothpaste. There's Crest, there's Pepsodent, there's another type. So the idea is you need to know if I'm using a certain type, how do I administer it? Okay? And so if you use something called PEDVAX, P-E-D-V-A-X, Haemophilus influenza B, or COMVAX, these can be used in infancy, 2 months to 4 months. However, and a dose would be also required at 6 months. However, if you used a DTAP, a DTaP plus HIB, H-I-B, combo, you can never use the combo products for the primary immunizations. Okay? So a lot of times, because we're giving so many vaccines, manufacturers are trying to put hepatitis and different components of various vaccines into one syringe. All right? But you can never use the combo in the first month of life. What other things would we look at? We talked about the IVP, the inactivated polio vaccine, the IPV. And remember that all children need to receive 4 doses of IPV. The 2 month, the 4 month, and then we're going to do one between 6 and 18 months, and then another booster prior to their starting school at 4 to 6 years. All right? So everybody gets 4 doses of inactivated polio. What about the MMR? Well, the important thing to remember here is that you need to give a booster dose probably between 4 and 6 years of life. However, if you miss it, you can give it after that. You need a second measles, mumps, and rubella. What else should you know about the measles, mumps, and rubella? If you've missed it between 4 and 6 years of life, you should have completed it by the age of 11 or 12 years old. Going down our list, thinking about varicella, remember that you can really give varicella at any visit after 12 months of age. The one thing that you want to make sure is that the patient doesn't have a history of varicella, because you don't have to give the varicella vaccine if you have already immunity. Some physicians or some parents may not have been diligent, and they may not have come at all the right visits for the well child, because why? They're thinking, well, my child is well. He never gets sick. Why am I going to see the doctor? If that occurs, you should find out if the patient had a varicella vaccine. And you need to remember that if the patient is a teenager, older than 13 years of age, and they have no history of varicella, that those particular patients will need 2 doses of the varicella vaccine rather than the one. And they should receive it 4 weeks apart. What other things are on the horizon? The pneumococcal vaccine. All right? Remember that, again, we have 2 types of pneumococcal vaccine. And we have the heptavalent pneumococcal conjugate virus, which is called PCV, and that's recommended to be given to children who are between 2 and 23 months of age. However, children who are in high-risk groups, children who, for instance, have sickle cell disease or nephrotic syndrome, those particular children should receive, in addition, the pneumococcal polysaccharide vaccine. So they should receive 2 types of pneumococcal vaccine. You might say, well, why? Well, remember that especially our sickle cell patients who had been in the past receiving the pneumococcal polysaccharide vaccine, they were still susceptible to various strains of pneumococcal. And just because they got the vaccine didn't mean that they weren't going to get sick with pneumococcal. Therefore, by using the 2, you have probably a chance of having a broader protection. We're almost to the end of the vaccine section, and I'd just like to comment about hepatitis A. As far as hepatitis A, it's only necessary to give hepatitis A in areas that are endemic. So you need to check with your health department in the states to see if they're in an endemic area. On your test, you would not know if Texas or New Jersey or New York were endemic naturally. Therefore, they would have to give you some evidence or some supportive piece of information that would make you want to give the patient a hepatitis A. All right? And then lastly, we're going to just mention the influenza A vaccine. The reason I mention this is that often this is confused with a Haemophilus influenza B vaccine. The influenza vaccine is not the same as Haemophilus influenza. All right? They're two different organisms. And so who would get an influenza A vaccine? Well, first of all, it's recommended for children who are greater than 6 months who are with certain risk factors. What would be those risk factors? Well, if they had if they had asthma, if they had diabetes, if they had some type of lung disease, heart disease, sickle cell disease, these children might be considered to receive the influenza A vaccine. Other things that you should know is that the vaccine is age appropriate, so the dose would be according to the age. You would not be responsible on your exam for knowing the dose. Who else could receive it? Anybody else who really wanted it if there was a sufficient supply of influenza A vaccine. But again, you should know that children who are less than or equal to 8 years of age who are receiving the influenza A vaccine for the first time need to have at least 2 doses separated by 4 weeks. All right, so if you're less than 8 and your parents want you to get, or your physician wants you to get the influenza A vaccine because you have asthma or cystic fibrosis, then you need to not only get 1 dose, but you would need 2 doses separated by 4 weeks apart. Right? They would get it each year. That's correct. All right. This actually brings us to our break. And I guess we could be back in 5 minutes. Thanks.